In today's video, we're going over the diagnosis of anterior shoulder instability in the joint. Okay, let's start the discussion off with a talk about instability versus laxity. So if someone is very laxed in the shoulder joint, usually they have a lot of range of motion, the capsule's a little bit more loose. They don't have true instability unless they have a sensation of apprehension or some sort of instability event like a subluxation or a dislocation. So just because someone's loose or lax doesn't mean they're unstable. So you can get anterior laxity and shoulder instability through a variety of ways. The first of which is going to be some sort of dislocation or subluxation. So oftentimes someone's playing a contact sport, the arm gets ripped into horizontal abduction, external rotation, and they'll either sublux. So sublux means the ball comes fully out of the socket and spontaneously resolves or goes right back in. A true dislocation is that the ball comes out of the socket and stays out of the socket. This could be a couple seconds or it could be a couple hours. And oftentimes these folks have to go to the emergency room, have to sometimes be put under anesthesia, put that ball being put right back into the socket. For a traumatic dislocation, there's a very high chance you have a Bankart lesion, which is a tear of the anterior band of the inferior glenohumeral ligament. So if you have a patient that comes in and you're pretty sure they had dislocation, you probably should send them to the doc. And the reason being is because they may do well with a primary Bankart repair over conservative treatment, and we'll talk about this a little bit later. I have a video for you to check out, but I won't get ahead of myself. The other piece is that you can have concomitant pathology. So if you dislocate your shoulder, ball comes out of the socket, there's also a chance you tear your rotator cuff. You could also have some nerve damage. So when you're doing your evaluation, you want to be on the lookout for those things. But the other piece is that if they do have a primary anterior dislocation, probably want to send them to the doc anyway. You can also have acquired instability. So if I'm a baseball pitcher, for example, I'm constantly in end range horizontal abduction and external rotation. We think about the arthrokinematics of the shoulder joint. When I go into external rotation and horizontal abduction, that's actually going to glide the ball forward in the socket. And the thought is it causes micro trauma. If you don't have enough rest in between sessions, over the course of time, you create more laxity in front of the joint. And sometimes that leads to instability or, like I said, apprehension in your patients. And lastly, a lot of your patients might just be born with a lot of laxity within the shoulder. So you may find they're a little unstable anteriorly, but if you have one of those patients, it's probably good to measure laxity in all different directions to see if they have some instability anteriorly, but maybe also posteriorly or inferiorly. And if they have instability in all different directions, they might have multi-direction instability. Now, the reason why it's important to have a good diagnosis is because your plan of care and your treatments may change based on what you find. So like I said, if you have a primary dislocation or first-time dislocation anteriorly, I'm probably going to send you straight back to the doctor, right? If this is more acquired and you have a little bit of apprehension but it's not bad, then I'm probably just going to treat you conservatively to start. And if you present with multi-direction instability, probably going to treat you again, but the other piece is that our treatments will change from having anterior instability versus multi-direction instability. So which populations are going to be the most common with anterior instability? For the primary dislocations anteriorly, usually this is in young athletic males. They're playing some sort of contact sport. So think about something like rugby, football, maybe wrestling, when the arm is being ripped into horizontal abduction, external rotation. The other mechanism of injury could be arm behind your body. So when you extend the shoulder back this way, the ball moves forward in the socket, it glides anteriorly, and if I land on the ground, it's going to push that ball anteriorly this way. It could also cause a dislocation. So it's important to know the mechanism of injury because that's going to clue you in on your future objective tests. From a history-taking perspective, usually these patients are going to tell you, hey, I had this event where I either dislocated my shoulder or I subluxed my shoulder. Sometimes they say they'll have feelings of instability when they're in certain positions, right? But oftentimes they're going to lead you towards that diagnosis.
To go along with the video today, I have a little gift for you. It's an evidence-based cheat sheet for shoulder instability. It's a 4-page PDF that goes over everything you need to know about shoulder instability. We go over prevalence, anatomy, joint arthrokinematics, risk factors, and different types of instability, causes of instability, whether or not your patient should undergo surgery or have conservative care like physical therapy, and finally, rehab implications for all the different types of instability. So if you're looking to get up to speed about shoulder instability in less than 10 minutes, then this PDF is for you. I'll leave a link in the show notes in the description. Go ahead and click on that and then download it and then get back to what you're learning about right now.
Also important to take note of how old the individual is. So if I have a very young patient, so under the age of 15, and they have a traumatic anterior dislocation, the chances of them having another dislocation is very, very high, okay? As you age, this starts to go down. So usually around 30 plus, folks have a less chance of having another recurrent dislocation. Reason being is probably because a lot of 30-plus-year-olds aren't going out there and playing rugby, right? They usually stop doing the activities that cause a dislocation. The other thing is that you start producing a different type of collagen as you age. So you actually have a stiffer shoulder after the injury and it heals down a little bit better. The other thing to keep in mind is the amount of dislocations or subluxations the patient has experienced. If I have a patient that's had a lot of dislocations, our research indicates they're probably not going to do very well with conservative treatment. Might have to send them to the surgeon. The other piece is if they have a lot of dislocations, it increases the likelihood of future osteoarthritis. So a lot of patients will come into you and say, hey, what should I do? Should I try physical therapy? This thing keeps popping out. The best thing for them may be to send them to the surgeon to try to take care of that so they don't have future recurrences and/or more osteoarthritis. So the next thing you can do is range of motion testing. But what I will say for the range of motion testing as well as your special tests, you have to be very careful. Your patient just came in on Saturday, they dislocated their shoulder in football, then on Monday you're evaluating it, you're pretty certain there's going to be some instability, right? You don't need to crank on that shoulder joint, and if you do, you can hurt your patients. And a lot of these special tests can be pretty provocative, and if you're aggressive with them, you're certainly going to lose trust with your patients. So go nice and slow, okay? So from an arthrokinematic standpoint, we talked a little bit about how we go into external rotation, horizontal abduction, and extension. That's when the ball goes forward in the socket. So when I'm doing my range of motion testing, I'm going to see two things. A, do they have apprehension? And B, where does it occur? So if I'm doing physical therapy and I want to see if I'm making progress over the course of time, I can see, hey, do we get a little further before we actually start feeling some instability? And this can be one of those things that kind of rules you into continuing physical therapy or referring to the surgeon because you're not making any progress, all right? So Michaela, let's have you scoot towards the end of the table. So we can start off by assessing external rotation. So I take the elbow tight to the side, I can go into external rotation slowly, see if I have any instability, any apprehension from the patient. How you feeling? You doing okay here? Yep. Excellent. We go a little higher and we externally rotate. We can also check horizontal abduction, and again, we can start a little bit lower, see if we're picking up any sensations of instability, right, and work away a little bit higher. The last direction I want to look at is going to be extension, straight back, and see if that creates any symptoms. And usually what I say for last is combining all the motions. So we go into abduction, external rotation, horizontal abduction, and I see if that creates any specific symptoms. Next, we can assess for capsular laxity anteriorly. Just keep in mind, laxity is not the same as apprehension or instability. So as you're doing this, we're assessing for how much motion is within the shoulder joint, but also if the patient has any apprehension. The other thing to keep in mind is that the degree of abduction, where you assess the capsule, will influence what portion of the capsule you're assessing. So if I assess with the arm at the side and anterior glide, that's going to be checking the superior glenohumeral ligament. If I go to about 45, this is more of the middle glenohumeral ligament. And if I go all the way up here, now we're assessing the anterior-inferior glenohumeral ligament complex. Now to assess this, all I have to do is choose the degree of abduction, and then from here I'm going to grasp the humeral head. You're finding first the acromion coming off of that where it's soft, and if you squeeze deep, you'll be on the humeral head. And from here I want to impart an anterior glide. And the idea is that your glenoid doesn't face directly out to the side, it actually faces a little bit anteriorly. So when I try to assess anterior laxity, I'm going to be pushing a little bit anteriorly, but also a little bit medially, just to go along the plane of the joint. So I go here, relaxing as best you can, and I'm going a little bit anteriorly and medially. Next, we're going to go over a bunch of special tests. Now for these special tests, a positive special test is going to be the sensation of apprehension and not necessarily pain. So if you get into these positions, the patient's like, yeah, that hurts a little bit, but it's not actually creating instability or apprehension, and that's a negative special test. You need to have that apprehension. Anterior apprehension test, your patient is supine. We're going to abduct the shoulder to 90 degrees. Again, very slow and careful. From here, I'm going to go into end range external rotation. I just be very cautious I don't go too fast. A positive special test would be the reproduction of the patient's apprehension or instability. Relocation test, I'm going to abduct the patient's shoulder to 90. From here, I'm going to slowly go into external rotation. You want to go to the point where the patient feels some apprehension. From here, I'm going to take my opposite side hand, impart a posterior glide on the humeral head, and ask the patient, does this reduce the feelings of instability in your shoulder? Release test, take the patient's arm, abduct it to 90. I'm going to impart a posterior force with this arm right here. I'm going to go to end range external rotation. And once I get to end range, I'm going to release my hand. Now this is a nasty test to do to your patients, but that reproduces the sensations of instability or apprehension when you release the hand. It's a positive special test. What I will say is that it's a great way to lose trust with your patients, and although it has a decent sensitivity and specificity, I still don't like it very much. This next test is the distraction test. It's really helpful for patients that are very guarded and you feel like you can't quite get them to end range and assess the apprehension. So you give them your phone, Fitness Pain Free channel, and from here I just want you to like all the videos. Just go through it, just say like. And while she's doing that, I'm gonna take the shoulder, I'm gonna ram it, boom! End range external rotation abduction, and assess for instability. Don't do this, all right? But do like the channel as well as subscribe. Anterior load test, we're going to abduct the patient's shoulder to about 45 degrees. From here, we're gonna apply an axial load, so I'm pushing at the elbow, trying to jam that ball into the socket. From here, this side hand is going to impart anterior force, maintaining that axial load. A positive special test will be a click or a clunk, indicating that the humeral head just came off of the glenoid. Anterior jerk test, we're going to abduct the patient's shoulder to about 80 degrees of abduction. From here, I'm going to apply an axial load, so I'm pushing at the elbow, pushing the ball into the socket. From here, my opposite side hand is going to impart an anterior force while I'm maintaining my axial load. And I push straight up. A positive special test will be a click or a clunk, indicating that the humeral head just came off of the glenoid. Anterior jaw test, I'm going to grasp the patient's elbow. I'm going to abduct up to 90 degrees. I'm going to take my grip just like so. And I want to grasp the humeral head just like this. And from here, I'm going to apply an anterior force straight up. And the way this is graded is on a 0 to 3 grade. So a grade of 0 would be minimal motion. A grade of 1 would mean you can get the glenoid, the humeral head all the way to the edge of the glenoid, but not off. A grade 2 would be you can actually slide the humeral head off the glenoid, but it spontaneously goes back into place. And a grade of 3, and I hope you never get to this, is you go fully off of the glenoid and the ball gets stuck there, you can't relocate it. So now you know a bunch about how to diagnose anterior shoulder instability. There's still another couple key points you need to understand in terms of what to do after you've diagnosed this. So plan of care, treatments, so on and so forth. So I have a video for you. I'm going to leave a link in the corner, and it's going to be 6 keys that physical therapists need to know about shoulder instability. So go ahead and click on that link, and I'll see you on that video.